It's really inspiring here today, and actually it's really great to see so many different people from the community interested in a public health approach to palliative care. So I do feel Alan set a bit of a high bar to follow as a presenter. I think he's also set me a few challenges about what hospices should do, many of which I do agree. I mean, I've been passionate about hospice and palliative care. I've worked in it since the 80s. I've been at St Nick's now for too many years that I want to remember, but I'm going to talk to you today about what I think hospices ought to be thinking about, and palliative care. I'm going to put all those of us working with people at the end of life. You know, what do we need to think about? What are the beliefs and assumptions we need to challenge? And I'm going to talk about volunteering, because that's something Alan mentioned. I know Libby's going to talk about it in a bit more detail, because I think volunteers can be a bit of a solution, but I think that brings their own problems. So I'm going to talk about that. And I'm going to draw on some research I did as part of my PhD, which was with community hospice volunteers, and touch on what we're doing at St Nicholas Hospice Care. So, inspiration. So I've drawn my inspiration over the years from lots of different people, from Cicely Saunders to our founder. We've got people writing now, Catherine Mannix, Kerry Noonan in Australia. But also, I'm also inspired by the people I meet, the stories I hear, and my presentation is going to finish with a woman who's working as a healthcare assistant in a care home, and actually she's inspiring. We hear all these stories all the time. We need to draw on them and do something with them. So, go back. So, death. As we know, it was something that used to be part of everyday life. Many decades ago, you'd have experienced many deaths in your family, grandparents, children. Death would have been something that happened at home. The person that would have supported you during that journey, you and your family, would have been your local minister, your local priest. There probably would have been a woman down the road who come and helped you lay the person out. People would have come and paid their respects. Children would have been taken up to see the dead body and do the same. It was part of life. And obviously with, you know, the advent of better sanitation, vaccination, antibiotics, you know, death has become less common, which is good, but we've become less familiar with it. And death is now something that generally happens, I know not mainly, but feels in the control of healthcare professionals. We look to doctors and nurses as the experts, and I've got some evidence about that later. And hospices have played the part as well. And I heard somebody speak at a TED talk, Jess Williams from Groundswell, said, as a society, we've outsourced death and dying to the healthcare professionals. We've sort of wanted them to get on with it. And I do think hospices have contributed to that story. We've got up and said, well, you're not very good at it. We're really good at it. Give us money and we'll look after and we'll do all the work. And I do think that has helped some people feel a bit sort of de-skilled. And how many of us sometimes think the best death would be in a hospice bed? But I don't know if you know, but there's nearly under half of us, that will be our view in our last days. Between 40 and 50% of us will die in a hospital. Now, I'm not sure if that's really where you'd like to spend your last days, but that's my daughter's bedroom with her dog. And that's where I think most of us would like to be cared for, in familiar surroundings with friends and family. I think the dog could be on loan for a price. She's lovely. So what have hospices been doing? Well, we have been doing a great job. You know, we've raised the profile about care for the dying and the bereaved. We've talked about it. We've improved pain control. But I do believe we've actually been given a bit of heaven to the few. And there was a whole book about it by David Clark. And I often talk to the team when I talk about thinking about this. And if you think, recently we did some research where we asked people where they would like to die. And 29% of people said they'd like to die in a hospice bed. Well, that's lovely. But only 6 to 7% do. And that's because we've only got beds for 6 to 7%. So it's like British Airways first class, isn't it? You go up the steps, you hope they're going to go, yes, madam, if you'd like to go to the left. But actually, most of us go in the right. So we need to make economy better. Very few people perhaps need the support of specialist palliative care, but everybody needs to be thinking about their death, their grief, their loss, and how they want to support each other. And we've got to get away from just making the British Airways first class better. We've got to make economy better. Because, I don't know how to tell you this, but we are all going to die. Mortality rate is 100%. It's not something we can avoid. I know some people think we might do, but actually it is going to happen to all of us. And demand, we know that we're all going to live longer, which is great, but we're likely to be sicker. We might have a bit of dementia. There's not going to be enough care about. The NHS is running out of money. Future looks really great, doesn't it? It's a lovely time to be old. So we've got to do something about this. And we also know that hospices are struggling. So the first hospice ever this year went into liquidation, Jarrow Hospice. Really sad, awful. They just didn't have enough money. They couldn't get the staff. They couldn't keep the inpatient unit going. Really important. A recent survey by Hospice UK said that 61% of hospices are dipping into their reserves to meet expenditure. So we've got to do something different, and I would say that St Nicholas is having the same problem as well. But rather than rushing out and seeking funding, we need to think about what we're going to do differently with the money we have. Because we have to remember, for the majority of hospices, most of our funding comes from our community, not the NHS. So we need to understand what's right for our community and what we can afford, rather than always chasing more money. So the way we're approaching this at St Nicholas Hospice Care is to try and design a new model. So when we saw I don't know if you remember, but earlier on we saw a graph with lots of cogs about civic, about generalist, about specialist palliative care, about community. But what does that specialist palliative care hospice cog look like? What's it made up of? And rather than just go, well, let's just do compassionate communities, community development, great idea, let's do more of that. But you can't do that unless the rest of your system changes, unless the rest of your organisation works differently. So we thought we'd approach this in a slightly different way, and that we brought in a company called LiveWork, who are a service design expert. Now that's very similar to King's Fund experience-based design toolkit, where what you do first is you don't just come up with good ideas, find some money and implement it. You talk to the people who are going through those experiences. So we went out and talked to 40 people about their experiences of dying, caring and grief, and not just people known to the hospice. Many of them had supported people dying in a hospital, in a care home or at home. Because what we knew is if we went out and said to people, what do you think of hospice care? How can we make it better? Half of them would have said, you're angels, you're marvellous, we just need more of you. The other half would have said, what do you do? Isn't that the place you die? And there'd be a bit in the middle. So we didn't do that. We asked about their experiences. And our ambition for this was actually to develop a model that has the capacity to influence everybody's experience of dying, death and grief, but also make our organisation sustainable and inspire a movement of social change that puts death and dying back into the heart of the community. But those were our objectives and our ambition. And I think, when I think about sustainability, somebody recently came up to me and said, so what do you think the hospice should be doing in 50 years? And I went, well, ideally, I don't think we should be here, because everybody should be doing it. I was a bit worried. I said, it's all right, we've got 50 years, don't worry about your contract too much. But when I met Dame Cicely Saunders decades ago, her ambition for hospice care was that if we taught everybody and equipped everybody to care for their dying and their bereaved, we wouldn't be needed. Whereas what's happened now, we have 200 hospices, palliative care teams, whole businesses becoming NHS providers, and I'm not sure if that's the real solution. So we went out and talked to people, and this is what they said. The importance of dignity. The importance of a social network, a support network. If they went through 2 periods of caring, the second time they cared for somebody who was dying, it was easier. They knew what to do. They knew what to expect. They knew who to call. The problems of out of hours, I know this isn't new, but it's really powerful to hear stories from people again. The hours that people had to wait for pain control. And one lady said, she said, do you know, I used to give my son injections when he was young. And yet I sat by my husband writhing in pain with the drugs there. I didn't know how to give it. If you'd shown me how to give it, I could have done it. In a moment, she said. Why weren't we doing that? So the themes that came out, which is very much in line and really is evidence that supports a public health approach, is that people wanted to be prepared. They wanted to have the time to do some planning. They wanted to have the right information, and they wanted to learn. They said, if you'd shown me how to do that, I could have done that. But I had to wait for you professionals to come, and you took hours. So if I think about birth, how many of you have children? Had children? Didn't birth, yes? Okay. So we nowadays would think it inhumane for a woman to go into delivering a baby without knowing what was happening, wouldn't we? But we're doing this with death. So when you have a baby due in the family, I know, I've had a few. You paint the nursery, buy the equipment, take the mortgage out for that, you know, fill the freezer, set up your support network, see who's going to come and help in those few weeks, who's going to do the shopping, hang the washing out, take the bins out, walk the dog. You know, you get ready. You go to the classes, you watch the videos. You read the booklets, you go online, you find out what you're going to be going through. You might have a bit of a birth plan, we know that goes out the window. But you are a bit, you know, socially, emotionally, your support network's prepared, you've thought it through. Why aren't we doing that for death? And this is what people said to us. They wanted that, they needed that. You know, they said the second time it made so much difference. They knew what death sounded like. They knew what it meant when that breathing changed. They knew that it was normal, that they didn't have to rush to the phone to ring 999. So I think really that's something we've got to think about what we're going to do. And some of this work's really being corroborated in Australia, work about social networks. And that diagram also supports this idea, is that we're not spending a lot of time with healthcare professionals. They're not that crucial in keeping the sort of the quality of experience. It's your friends and your family and your dog and your neighbours, your bowls club that comes to visit. It's all those different friends that support you and the people looking after you. The doctors and nurses are important, but they're not the most important for some of the experiences, but they can also get in the way. And some of Debbie Horsfall's research in Australia said that professionals can get in the way, where they sweep in and go, well, you can't possibly do that, he's going to have to be admitted. Well, you can't do that. Well, that's just not, you know, you haven't got the right bed, the right equipment. And we can hear all these stories, aren't you, where families are desperate to try and do it, but all our systems and beliefs and processes get in the way. Okay, so I'm going to talk a bit about volunteers now, because volunteers, when you think about hospices delivering at scale, supporting people in the community, volunteers are sometimes seen as the solution. Now they can be, I'm not saying they're not, but I think we've got to really think about what it means and what volunteering means. So I was really interested in this a few years ago and started a PhD for my sins, and have actually finished it now. I've never thought I would. And I talked to 16 volunteers who supported people, were visiting people at home. And one of those schemes was Hospice Neighbours at St Nicholas, but there were 3 other hospices where I interviewed volunteers as well. So there were sort of 2 themes that came out. There are lots more. But 2 themes was one about friendship and one was about rules. And people, and I'm going to read you some of the words because, you know, there's a lot of feeling about should people become friends or not become friends, and what are the boundaries and what you can do and what you can't do. I can hear you nodding. So one of the people I interviewed, and the names have been anonymised, Sarah said, so we might maybe becoming friends, but she says, I suppose I can't see how you can spend that amount of time with someone over that length of time and not become friends. And it really enhanced my life knowing her. Another volunteer felt a bit differently. She said, I feel if you've got a close relationship, you should be there as a friend, not as a volunteer. And another volunteer said that what was really lovely is how the person he was visiting, Tom, who had dementia, and Edna, his wife, and the tortoise, sort of became part of his family story. He said, when I came home on a Thursday, the wife said, how did it go? And I got to tell stories, and they had a tortoise who'd walk up to you in the garden and headbutt you, well, shell butt you, he said, and you share that with your children, and they say, what have you been doing, and how's Tom? And it sort of becomes part of the story about visiting people who are dying. One of the volunteers was really interesting because she'd been doing a lot of volunteering through her professional life and as she retired. And she used slightly different language, which is interesting. She said, I think for the other clients, because I've known that they've a terminal illness that may cause them not to live very much longer, I've been able to interact with them in a way that they wanted, but then I put it away and then brought it back at the front of my brain at the next visit. So very sort of clinical medical language. But then she talks about the person she's visiting at the moment, which has been going on for some time, where she says something that it's become more long-term. It's not that I come home and think about her a lot, but there's situations where I think, oh, I must tell her about like that, like you would a friend. But many volunteers felt you couldn't be a friend and a volunteer as well. And that was because of rules, okay? How many of you work with volunteers? Okay, do you have rules? A few? Many? A lot? So certainly, particularly with hospices, so I'm going to talk about hospices here, they did have quite a few rules. Like don't give out details of where you live and don't give out your phone number. But some volunteers said to me that really does seem a bit of overkill. And they say, oh, well, if it's rural, it's fine. I tell them roughly where I live, because I think it'd be rude and slightly offensive if I didn't trust them. So they trust us, but we don't trust them. Sarah said, I suspect I break the rules a little bit, she says, but I can't sit and have a conversation with someone and go visit week after week without them knowing a little bit about me. I know Libby's going to talk about this sort of reciprocal relationship later, but a lot of people worried about that they'd got too close. So Anita said a few of the volunteers, they've had people die and they've got quite close to them, which you're not supposed to. And Anita told a lovely story, which really sort of is an example of some of the things I heard, where she was on her way to the support at the hospice. Some people call it supervision. And she'd been to see her lady with MND, and she'd taken, it was Easter time, so she'd taken some daffodils, but that wasn't allowed. So she says, so all the way to the hospice, I had this little joke with myself. Don't mention the daffodils. Don't mention the daffodils, Anita, whatever you do. And I went, oh, Kate's deteriorating and it's getting to the point where she can't go to the toilet, and husband's arranged for someone to help me. And they went, oh, that's good. That's really good. That's how it should be. And she said, and we had a nice little chat, and I took her some daffodils, and she said, and everybody looked at me. And how sad is that? It really is. So you know, I learnt that the experience of visiting somebody who was dying transformed how these participants thought about life and death. Death became less scary. They kept saying to me, everybody said it would be really hard visiting dying people, but it was easy. They were like you and me. It's not us and them. We're all in it together. They loved visiting in the community and being autonomous and flexible and developing that relationship, unless somebody got in the way. If you think, a lot of volunteers start volunteering because they want to get away from their professional life, get away from bureaucracy, not have more bureaucracy and rules as a volunteer. Also, the rules didn't make sense to the volunteers. It didn't fit their experiences. One thing I didn't see in any of the literature I reviewed is that volunteers often said to me, well, you know, when I talked about how is it after somebody died, they said, well, it's a bit like doctors and nurses, isn't it? You learn to live with it and move on. And that was a theme that came out time and time again. And also they said, you know, I need to try and be a professional. One volunteer said that she went to the funeral, did a reading, left her badge off, went to do the next visit, put her badge back on, so she was a bit more professional. And for me, I think that reflects how death's become medicalised and in the realm of healthcare professionals, that people haven't got the role models in their community about what it's like to be with somebody who's dying. So the only role models they're drawing on are healthcare professionals, because they seem to know it best. But rules from the system were definitely getting in the way. And if you think about Alan's donkey and the camel, we all carry with us sort of bias and belief systems from different systems, from society, from regulation, from our community, from our own experiences. So we all carry that sort of interpersonal belief system about from your professional life. So volunteers who'd worked in professional systems were much more inclined to stick to the rules than the volunteers who didn't. One group of people that didn't like sticking to rules were teachers. They tended to go, well, there's just guidance. I'll do what's right for the person I'm visiting, thank you. But then didn't tell the hospice. And I think it's really interesting. So a lot of the literature said that, you know, what you do if volunteers aren't sticking to the rules is that you just train them all. But tell you what, that doesn't work. So going back to the challenge of hospices, I do think, you know, this book, I can't believe this was written 9 years ago, but they said, we started off as innovators, is disrupting the system and challenging that sort of the way we were doing death. And now we've become part of the system and part of those rules. And actually we need to get back to doing things differently. So one of the really stark examples is if you had a friendship, these are the things that would be normal in a friendship, wouldn't they? About sharing about yourself, advice, friends on Facebook. But some of the rules that the volunteers talked about that the hospice gave them was don't get too close, presumably because it might be upsetting. Keep everything completely confidential. Now, volunteers weren't differentiating about what the stories you could tell and what you couldn't tell. So that meant, those amazing stories of their experiences, they felt they could only tell within the medical hospice system. And we weren't hearing those lovely stories in their friends and their community. You certainly can't give advice. One lady said very much, you know, all these pads arrived when I was there, and the husband went, oh, what am I going to do with these? Because she's a bit incontinent now. And she wanted to say, what you need to do is you need to go to Boots to buy these really good knickers that hold these pants, the pads on, because the ones that come with them aren't any good. But she felt, oh no, nurse needs to do that. So we've really disabled people. So I think that you can see where these rules are clashing and where we have to think differently. The first most important part of our strategy is equipping everyone. So our mission statement isn't not to deliver the best services, but our mission statement is for everyone to be informed, equipped and able to live with dying, death and grief. So if we get that right, we then probably won't be needed. I don't think it's going to happen overnight. But it is about equipping, and somebody said, oh, it should be enabling, it should be facilitating, but I wanted it to be an active word. I want our team to understand that they need to be equipping everybody else to do it better. There are still things I think that we are needed to provide, specialist palliative care, how we provide that equitably and not just to those that get referred and tick the right boxes, I think is really important, and that's what we're testing at the moment. But I think also we've got to always strive for innovation. We've always got to strive to do the best. We've got to strive to be well run, to use the best use of our resources and to be sustainable.